Hello, San Diego moms. How is everybody doing? Just give me 1 minute. I'm going to go live on Instagram as well here. Maybe. Of course, technical difficulties. Oh, there we are. All right. Well, we are here, and I'm here with Dr. Lauren Sievers. We are here for Food Allergy Awareness Month, and this is week 3 of our live stream series. So thank you so much for being here. I really appreciate it. How are you doing today?
I'm doing great. How are you?
Doing good. It's a beautiful day out there today.
Yeah.
And why don't we just give people a few more minutes to kind of hop on here? But you could just share a little bit about yourself. You're a local San Diego native.
Yeah. I grew up here. I grew up in University City, went to UC High, and then graduated. I went to UCLA for undergrad, so left for a while. I did my medical training in Michigan, and then lived in Pennsylvania, and then I came back. Couldn't stay in those winters anymore. Wanted to be back. So I've been in Carlsbad for the last 4 or 5 years now.
Yeah.
I love it there in North County. Yeah, it's very, very nice.
That's amazing. And how long have you been with the Food Allergy Institute?
I've been here. This will be 3 years in the summertime. Yeah,
Okay.
This work is so much fun. It's just really cool to see patients come in that are very, very, very allergic, have to limit a lot of things that they're doing in their lives, and they're leaving just being able, like when they graduate from their program, it's a lot of hard work. They graduate and they're able to go to birthday parties, go to sleepovers, eat out at restaurants, fly on airplanes, and like things where their life was very limited. And so I feel very blessed to be able to do this work and to walk with families through that. It's been a nice job to come into every day.
Very cool. No, it's been so great to hear the stories and just kind of meet the doctors and go through this kind of as well, just from a mom's standpoint that, my child doesn't have allergies, but I think it's so important for both to kind of share the awareness for parents maybe who are struggling with it, as well as, I think the likelihood that your child might have a friend with food allergies, it's important that we're all, aware of, I guess, the severity of those types of things.
Yeah.
And today we are going to be busting some common myths and misconceptions around food allergies. And so I would love to I think that's probably something in any area of life where if you have a misconception or just kind of a thought on something, it might, that belief could make you not think that remission is possible, I think so. We'll set the record straight. And so I'll kind of share just some common myths. And if you guys have any questions, you can drop them in the chat as we're going along, and we will be sure to get to them. So let's set the record straight.
Okay, let's do it.
Food allergies and food intolerances are the same thing.
Okay, this is a good question. So they are not the same thing. When you have a food allergy, your body's making these little tiny proteins that are called allergic antibodies, and that causes you to have symptoms like hives, difficulty breathing, swelling, in extreme circumstances, might cause you to pass out. This is a very, very dangerous situation. Intolerances can make you very uncomfortable. You may have belly pain, you might have nausea, or even something really gross like diarrhea, but it's not going to cause a life-threatening reaction. A true food allergy can potentially, depending on the severity of the allergy, cause a life-threatening reaction. So we think about those things very differently, and the treatment is different.
Yeah. So a small amount of the allergen won't hurt.
Okay. There is a big spectrum of food allergy. Some patients can tolerate, and some people can tolerate that. Other people really cannot. And even micro doses like cross-contamination, something touching another food, even though you're not eating the actual food, can cause an allergic reaction. And you really don't know for any particular person or any particular situation what the severity of the reaction is going to be. It may be that you've had mild reactions in the past and your body's becoming more and more sensitized. And so now this thing that used to be mild is getting more severe. So small amounts, yes, can absolutely cause anaphylaxis and severe allergies in some people.
Yeah. And I think it's funny. I feel like that's something my mom, I think I talked about that in the last live stream, it's kind of an old school kind of thought is like to push that out. And obviously I know it's a big part of the treatment, but just, it's funny. My mom is special. And we did get a question in here. Do you treat lactose intolerance?
You know what? I wish that we did. We do not. So it's not everything that we treat is food allergy. And so we can't treat the lactose intolerance. There are no known treatments that I know of for lactose intolerance other than taking the lactate pill before you eat dairy, or just drinking lactose-free dairy or eating lactose-free cheese. Unfortunately, we can't. But it is a lot of people have lactose intolerance, and it does make you very uncomfortable. And dairy is very delicious, but we don't treat lactose intolerance.
That would be a tough one.
Yeah.
All right. You can outgrow any food allergy with time.
You know, you cannot. There are people, small children, that will be diagnosed with something like egg allergy or dairy allergy. And we like to say they build tolerance to that allergen rather than they outgrow it. And they will start to be able to tolerate small amounts of eggs and bigger and bigger and bigger amounts of eggs. And this is a wonderful situation when that happens. It does not happen for a lot of patients. And things that will make you less likely to outgrow an allergy are a more severe allergy, like higher markers when we check, and an older age. Once you're getting to around kindergarten age, the immune system is pretty mature, and it's very, very unlikely you're going to outgrow allergens after that age.
And then this is just a kind of question. Are there, I know you mentioned dairy, are there specific foods that kind of you see more typical, where they might transition out of?
Dairy and eggs are the most common ones to outgrow. If you had a very mild nut sensitivity, I suppose is possible. We don't see it as commonly with the nuts and the peanuts, unfortunately. I wish it was more common, but we think that process of outgrowing is a process of building tolerance.
Yeah.
You build tolerance by eating similar foods. So if you're eating a lot of beef in your diet, this may help if you have a very, very mild milk allergy. Not a lot of people are eating things that look similar to a peanut and to tree nuts.
Yeah.
And so we think that may be part of the reason, but a lot of that is unknown.
And then why don't you talk a little bit about the tolerance induction program, and just kind of dive into maybe the differences. Sorry, I'm having an eye issue right now.
Oh, it's okay.
If you could just talk a little bit more about the program, I just totally went.
I will.
If you could just talk a little bit more about TIP for us and share a little bit on some of the allergies that you guys treat.
Sure. Yeah. So the tolerance induction program, we are based out of Long Beach, and our first satellite clinic is here in San Diego. So that's excellent for our San Diego families. We're planning to make more expansions. We have families come from all over the world to treat food allergies here. And the reason for that is this treatment is very successful. It's a lot of work. It's not an easy thing to do, but if you're willing to put in the time and effort to do it, it's extremely successful. How it works is we do very thorough testing, skin prick testing and blood testing, to determine what a particular patient is allergic to and how allergic they are to those foods. Based on that profile, we can make a plan for them that includes biosimilar or foods that are cousins of their allergic foods. So say, for example, you have a very severe peanut allergy. There are other foods out there in the world that are cousins of peanut that don't look exactly like peanut, and you're not allergic to them, but we're going to use those cousins to build tolerance to the peanut so that by the time we get to peanut in your treatment, your body is ready, and then we start on really, really small amounts and increase like that. We treat all food allergies here as long as it's an IgE or allergic antibody mediated allergy. We can treat it here at Food Allergy Institute. So this includes all the top 9 allergens: peanuts, tree nuts, seeds, shellfish. And this includes less common ones: fruits and vegetables, different kind of grains, beans, lentils. There's you can really be allergic to almost any food. And so we see more rare things too.
Thank you. I'm sorry, my eye had to make a palpitation there. Sorry about that. We did get another question here. Let's see, I'll put it up here. What would you say to the view of other allergy experts that no doctor can ever guarantee food safety? Should you be wary of them? SoCal seems to have a high success rate for food freedom.
We do. And this is a really good question. And I think it is wise to any decision that you're going to make for your child or yourself regarding your health. It's wise to do your research. The reason that we know our program is successful is it's really tailored to the patient. And we slowly build that tolerance over time using those similar proteins. And then even when, say, for example, peanut allergy, when we start into peanut, we're starting with micro, tiny doses and working our way up. You're dosing these for a long, long time. And so we're monitoring through all of that. We have 24-hour support and all the email support and phone support, and we're watching what's happening with each patient. Any issues that arise, we're checking labs and doing other testing and trying to get back on track. Once the patient graduates, we're watching them in remission too. And it's not to say that no patients ever have any issues, but we want to get to the bottom and figure out any reason that that patient is having issues and figure out what the treatment for that is. Patients that are deep into remission, meaning they've been in remission for 2, 3, 4, 10 years, it's extremely unlikely for that patient to have a reaction. They would have to stop eating their allergic food like for months and months and months. So I guess that your doctor's right. You can never say 100%, but we know just from watching a lot of patients that that's very, very rare thing that happens based on the way that we structure the program.
Thank you. And just as a reminder, if you have questions, feel free to drop it in the chat. We will continue to answer them throughout the live here. Let's go to our next myth. You don't need an epinephrine auto-injector unless you've had a severe reaction before.
Okay, so an epinephrine auto-injector, EpiPen, AuVQ, there's a lot of generics for EpiPen. It is the recommendation now that if you have had a food allergic reaction, meaning you had hives, you had swelling, vomiting, difficulty breathing after eating a food, it's probably wise to carry that Epi because you don't know. Sometimes the first reaction is more mild. The second time your body's triggered, it's kind of like sitting there waiting, ready to go, and it's going to be more severe. It's just hard to say for any particular person. So it is wise if you've had an if you've had an allergic reaction to a food, the wise thing to do is to carry that Epi and just know that you or your child, whoever has the allergy, is safe should something happen. Epi's very easy to use. Put it in the leg. Everyone's worried about the needle, but honestly, you don't even see the needle. It goes right into the leg, and it's a life-saving treatment. It really is. It should be more widely available. So that's something we recommend for any patient that's had any kind of allergic reaction.
Thank you. And it looks like we got a few more questions in here. I'll put it up on the screen. What is the time frame duration of a treatment on average?
Good question. It depends on the severity of allergies and the number of different types of food proteins. So someone that came in with like a more mild peanut or tree nut allergy or both, we're probably looking like in the 2 to 3 year range. Patients coming in with very severe peanut allergy, severe dairy, wheat type of allergies, we're probably looking more in like the 4 to 5 year time range. Patients with many severe allergies, it may even be close to 6 years. So it really depends. We won't know for any particular patient until we do the testing and know what their treatment plan is going to be.
Yeah. Which, I mean, I don't think it matters how long it would be when you look at it in like the bigger scale. I think it's so worth it.
Exactly. That's my opinion, but I'm biased. This is my job. This is what I love to do. But yes, like when you achieve that final visit and you really have food freedom to everything, that is just such a weight off. And honestly, you reach food freedom for different foods as you're going along your program. So you may say you come in with dairy, egg, and peanut allergies. You may clear that egg halfway through your program. You're still working on dairy and peanuts, but you're eating eggs. Like you're going to breakfast restaurants and like, so there are milestones that we hit along the way during the programs, and that's nice too.
Yeah, to kind of keep you going.
Mm-hmm. Mm-hmm.
We got another question here, just really quickly. Do you know anywhere that would treat adults with food allergies? I became allergic to pretty much all fruits and vegetables at the age of 32, and constantly breaking out in full body hives.
Oh, I'm so sorry. That does not sound fun at all. That's a great question. We currently treat patients enrolling up to the age of 25. So young adults, that is as much data as we have right now. So the age limit has gone up as we've treated older patients. So it used to be 18, now it's 21, now it's 25. As we gather more data, that age limit will come up. Now they are doing a trial of adult treatment with a very small group of patients in Long Beach right now. Depending on how that goes, we may be able to open up treatment to adults older than 25. But right now, I don't know of any particular centers doing food allergy treatment for adults. I don't know. I know that we don't, but my knowledge outside of our clinic is limited. So I can't say for sure if there's other doctors in San Diego treating.
Well, hopefully.
Yes.
In time. And Katie is one of my good friends. And so as her friend, it's hard to see. So I have a really good friend too, as well, with a garlic allergy. And I'm like, also developed much older.
Yeah. Yeah. Sure. Yes, we will. We will. Yeah. I'll have to let you know. Yeah. Yeah.
All right, let's go to our next one. Food allergies are caused by overprotective parenting or too clean of environments.
There is this, it's called the hygiene hypothesis. Food allergies are becoming more and more and more common. So a lot of people want to get to the bottom of this. Like, why is this happening? Like, we can't keep going on like this. Like, this is really, it's life altering. One hypothesis that's been shared is possibly maybe the immune system is looking for something to react to. We used to, 100 years ago, 200 years ago, we were a lot dirtier. People walked without shoes. You played in the dirt more. Like, just in general, kids were outside. There wasn't Clorox wipes and things like that. Has that contributed to food allergies? We don't know. I will tell you from personal experience, I've seen a lot of patients come in, they play in the dirt all the time, and they have food allergies. Patients come in, the mom's like wiping the table down as a child's in the room. They wipe the airplane seats down and all these things. The patient has food allergies. So anecdotally, sitting here in my office, I haven't seen that bear out. The data also doesn't support that that's absolutely the case. Probably in the end, and it's an active area of study, probably in the end, what we're going to find is it's a combination of things. There are some genetic factors that we know, like when you talk to families, yes, I have eczema, we have eczema, now the child has food allergies, things like that. And there's probably some environmental factors. Like, you can have identical twins where one has food allergies and the other one doesn't. What's the story there? I don't know. So it's something that we have to continue researching, but we don't know. You can't say with any certainty that's because the environment's too clean. There's just, there'd be no way to know.
That's good news for me because we're not doing this stuff. But, and this might be a dumb question. Sorry. When you said genetic, so like, is that hereditary? Like, are you saying like,
yes, hereditary? Yeah. So like running in families and sometimes when you trace the family history back, they'll be like, oh yeah, granny so-and-so, remember she always had hay fever and she's sneezing and stuff. And then you look down through the generations and kind of everybody has some kind of like allergic issue, asthma, eczema, but that's not the case in every family. We'll see patients where there's no history at all. And all of a sudden the child has this very severe wheat allergy. So there's no, there probably is a genetic factor, but that's not the whole thing. Yeah. That's not the whole thing. Yeah.
More to look at. So a negative skin or blood test means you're not allergic. Does it? Or I guess that's,
it's always nice to have a negative test. This is very nice. We know by looking at the data from a lot of patients, thousands and thousands of patients, that a negative skin test, because it's common in the community to use a negative skin test and then do a food challenge. That's very common. Sometimes it fails because a negative skin test or just a negative blood test doesn't give you the whole picture. It doesn't tell you what other foods the patient's eating. What is the patient's history? How long have they been avoiding the food? When was the last reaction? You really need that very thorough history to know what's going on with the patient. And then, even then, if the patient's had symptoms, it is never wise to just go ahead and give a food based on a negative test. We want to start with really small doses and make sure the patient tolerates that food first, because you can't really, that testing, it's great to have a negative test, better than a positive test, but you really always want to be cautious when introducing something new, because you can't say for 100% a negative test means no allergy.
Yeah. Are false positives a thing in this field?
Yes. And so that's why we want to do a positive test. Doesn't necessarily mean you're going to react. So the opposite's true too. We'll have patients that come in, they eat whatever it is, peas. They eat peas all the time. And they test positive. Blood test is positive for peas. The skin test positive. And they're like, we eat pea protein every day. We drink Ripple milk or whatever it is. And I'm like, don't stop eating it. Keep eating it. A positive test doesn't always indicate that you're going to have a reaction. So testing is, we use a lot of AI and machine learning in the way that we evaluate patients' data, their data being their blood testing and their skin testing. And that helps, that's based on all the thousands of patients that have come. That makes it a lot more accurate to kind of know what proteins they're allergic to and what they're not, because you can have false negatives and false positives. Yeah.
Thank you. So OIT and TIP are the same thing. And maybe
Okay,
you can explain OIT too as well.
Yeah. Okay. So OIT is oral immunotherapy. And this is confusing because you would think, okay, oral, meaning you take it by mouth, immunotherapy, meaning like immune system therapy, meaning you're like treating something, right? So you're treating your immune system. Okay. You think, well, TIP is treating the TIP is tolerance induction program. That's what we do. We are treating the immune system with food. In OIT, they're also treating the immune system with food. The big difference, well, there's several differences, but take a long time to explain. One of the big differences is doing all that comprehensive testing, figuring out which proteins the patient's allergic to and any similar proteins and how allergic they are to those. And even within a certain protein, if you have a peanut allergy, there's several proteins in the peanut you can be allergic to. And each peanut allergy is actually slightly different. So we need to know which proteins, and then we're going to slowly start in with those biosimilar foods and work our way up to peanut, and then dose tiny, tiny amounts of peanuts. With OIT, the plan is the same, kind of like across the board. Now, we don't do OIT, so I don't want to get too much into it, but there's kind of a standard dose that all patients who qualify for the OIT are receiving. And you're starting right in on, say you're doing peanut, that's the most common one. You're starting in on the same dose for every patient. And that might work if you have a really minor thing going on. It's going to cause reactions if you're a more severe case. So that makes it very difficult. You also, with OIT, it's kind of a lifelong dosing that you're doing of, however many peanuts or whatever food it is that you're getting up to. We find that this is unsustainable, particularly when patients are getting to college. They're not going to dose the food every day. And so what we want to do is we get up to very high doses, which allows the immune system to become tolerant. And then we can space the food dosing to like weekly or every 2 weeks. So those are the biggest differences. We want to tailor the treatment program to each patient. And that, unfortunately, not yet. That's not the case for OIT at this point.
Yeah. I mean, I think definitely having an end in sight would be key as like a parent and as a, somebody going through the program.
Yeah, we know OIT has a pretty high reaction rate too, and that's not good. That causes, obviously, the danger of the reaction plus the anxiety that it causes for the patient and the family. It's just, it's not good.
Awesome. Thank you. It looks like we have another question. How often would you recommend to have a blood allergy test done? And would you recommend having that done before major signs, allergies, or allergy symptoms?
It's tough. So in pediatric patients, really young patients, babies, toddlers, really up to kindergarten or first grade age, their immune systems are maturing. And so you're going to see some change in those tests. And so for those patients, it might be wise to check yearly and check in and see how they're doing. For older patients, it's really hard to say. This is not a typical allergy practice. I think the standard out there is to check yearly. If your child or yourself is really older than elementary school age, there probably is not going to be a whole lot of difference. Now we can never say for sure. Every patient is different, and it would be best to listen to the advice of your allergist. But there may not be a whole lot of change if you're 15 years old with a severe peanut allergy. The next year, you're probably still going to have a severe peanut allergy. Now, whether other things have popped up is possible. So that may be one reason to do testing. So it's really hard to say. If you have had a minor something happen, it would be good to test before you have something major happen. If your plan is to avoid, say, for example, the garlic, you had hives when you had garlic and it's the garlic and you're not planning to treat it, then you can avoid. That's always a safe option. It's kind of like whenever we run a test, we always think, well, what are we going to do with the results of this test? If the results are going to be the same and you're not going to change your plan, then you're putting yourself through the trauma of the blood draw and the cost without really changing anything. So it's really hard to say. I would, in that case, like kind of just ask for the advice of your treating provider, because every patient is so different.
And you don't go in and do an allergy test unless you have a reaction, correct? Like with children, is there
Some patients, if they have a sibling that has food allergies or they have really severe eczema, the parents will request the testing.
Okay.
And I have seen patients come in to where they've never had their allergic food. They just know based on testing.
Okay.
For older children, I think usually, and adults, it's usually because you've reacted to something. Yeah.
It looks like we have one more question here. Once a patient completes the program, what does maintenance look like? Are they completely free from the allergy?
Yes, we say that they're in remission. We never say that they're cured from their allergen. They have to maintain that food when they come to their remission appointment or their graduation appointment. They'll keep on with that food once a week. So say they are finishing out their dairy program. There's going to be a certain amount of milk they have to drink once a week. The rest of the week, they can drink milk or not drink milk. They can have ice cream and cheese and the whole thing. But once a week, they've got to get that, whatever it is, 6 ounces of milk in. Same thing for peanuts. It's similar for every protein. There's something they're going to have to do weekly. And the foods that they've been working on, they're going to have to do weekly too. So if they have other allergic foods, they're going to have to do those too. As we watch these patients go out into remission, we'll watch once a year, check in with blood and skin tests, check in how has it been going at home, how are you doing with dosing your foods. As the data shows us that their body is getting further and further into remission, we'll space those foods to every 2 weeks, every 3 weeks, and then finally our goal is every 4 weeks, so once a month, which is a very reasonable amount of time. And really probably everybody, allergic or not allergic, should be getting these foods in about once a month.
Yeah.
And so
And
that's the goal.
dose, sorry to interrupt. When you say dose, it's like the actual food, right? They're not getting like a something from you guys.
Yes. That is a very good clarification. When we started on dosing, we dose tiny amounts, and we'll give you those amounts because they're just so small. They're microscopic. You couldn't measure them. Yeah. But eventually, the goal for all foods is that you're eating the food. If it's sunflower seeds, you're eating seeds. If it's peanuts, you're eating peanuts. If it's milk, you're drinking milk. So the goal is always to get to the actual food, and so you'll be eating the actual food daily while you're in the program, when you graduate weekly, and then eventually we want to space to monthly once the data shows that your body's ready for that. That's a great question.
Makes it a lot easier. And then I have another dumb question because I feel milk and lactose. So to her question earlier, so obviously they're different because you guys treat dairy. Can you just explain that difference just for me?
Okay, milk contains carbohydrates, proteins, and fats. Okay, like remember back to high school biology, there's carbohydrates, proteins, and fats. Okay, fats is not an issue. Everybody worries about fats. That's not related to intolerance or allergy. The carbohydrate in milk, the sugar, is lactose.
Okay.
And if you're lactose intolerant, it means that your body can't break down that sugar, and so it can't absorb it. And so it's just hanging out in your gut, and your bacteria are eating it up, and they're causing you to get gassy and all this other abdominal pain and stuff. Dairy allergy is the protein component of the milk. So people allergic to dairy are allergic to the dairy protein. And all food allergies are like that. You are allergic to the protein component of whatever food it is. Peanuts, seeds, every food has, even though maybe you don't think about it as garlic, how much protein does garlic have? Very little. But the protein in there is what that person is allergic to.
Interesting. Okay. Thank you for clarifying. If your child has mild reactions, their allergy isn't serious.
Okay, so it's always good to have a mild reaction instead of a severe reaction. This is very good. In these cases, that person may go on to only have mild reactions, and that's a wonderful thing. Okay, not wonderful they have reactions, but great they're not having anaphylaxis. However, sometimes we'll see that with each reaction, the body becomes more and more sensitized. Like we were talking about, it's kind of like becomes like on alert for this thing. It's like waiting. And so there is a risk with each reaction that it becomes more and more severe. That's not the case for every person, but it definitely is a risk, and it's something that we see commonly.
Thank you. And that was our last kind of myth that we had.
Myths busted. We did it. That's great.
And thank you for answering my questions too. I appreciate that. So if you have any other questions, feel free to drop it in there now. And thank you so much for your time. I really appreciate it. You've been so great to chat with, and I've learned so much over this course of this whole entire month, and I'm so excited. And it's been great to kind of be able to join the cause for Food Allergy Awareness Month. And we will also share this on SanDiegoMoms.com, so you guys can find that later today. So come back to it. Anything else you wanted to share or kind of add to the?
No, thank you so much for having me. this has been like a really great opportunity. This job has been really, practicing medicine is always very rewarding. This job in particular, I found rewarding because we see the actual success. If you treat a patient for, say, for example, you're treating them for high blood pressure, maybe you see their blood pressure come down, but really on a day-to-day basis, it's not affecting their life. In the end, you're affecting, you don't want them to have a heart attack or a stroke or something. So it's long-term. In this, we're seeing this like immediate success. It's really cool to be able to say like, your child's clear on peanut cross-contamination. Like they haven't cleared peanuts, but now they can have M&Ms. They can go to an ice cream shop. They can have Chinese food and just say, we're peanut allergic, but if a little bit gets in there, they're fine. Like those kind of milestones, and especially the remission appointment, of course, it's just like, it's a wonderful thing to see. And so this work is very cool. It's going to continue advancing for the food allergy community. We're working really hard to find solutions that are available because it's something that a lot of families are struggling with. So thank you for having Food Allergy Awareness Month. Our patients appreciate it. We appreciate it.
Yay. Well, thank you. Thank you. And we will drop links. You guys can go. They host monthly webinars. They also have kind of an ask a doctor or have a consultation option on their website as well. So we'll drop the Food Allergy Institute's website in the comments. And we will see you guys next week, which just really quickly, we will be sharing next week, anybody that's interacted or asked questions throughout this month. We will be going on and giving out some really cool prizes like movie tickets, New Children's Museum tickets to our next event, Dadchella, on June 8th, and lots of fun stuff. So we will see you next Wednesday at 12 o'clock. And thank you, guys. Thank you, Dr. Sievers.
Bye. Thank you. It's a pleasure.